in health law and bioethics, and he's board certified in internal medicine. He has served as president of the American Society of Bioethics and Humanities, the National Bioethics Professional Association, and he's received its Distinguished Service Award. Among his other awards is the National Council of Teachers of English George Orwell Award for distinguished contribution to honesty and clarity in public language, the American Bar Association section of Individual Rights and Responsibilities Human Rights Hero, and the Sullivan Ballou Fund Award for Human Rights. He's published 4 books, more than 20 chapters, and over 200 medical articles on medical ethics, human rights, tropical medicine, and end-of-life care. He has served as medical director for the American Refugee Committee for 25 years, which has included service as chief medical officer for over 45,000 refugees on the Thai-Cambodia border, as well as projects in the Sudan, Croatia, Bosnia-Herzegovina, Indonesia, and the Thai-Burmese border. He is on the board of the Center for Victims of Torture in Minnesota. His work has changed healthcare insurance, end-of-life care, the use of restraints in nursing homes, refugee camp medicine, and prison medical ethics. And today he will be speaking about the Affordable Care Act. Please join me in welcoming Dr. Steve Miles.
Thank you, Britt. Good morning, everybody. I'm not sure I have breadth of field to take you all in, but we'll try. We're going to talk about the Affordable Care Act today. If you are over 55, you have lived through a comparable revolution in the U.S. healthcare system. Everybody who's under 55 has not. 55 years ago, we enacted Medicare reform. I got a simple set of objectives today to describe the background for the Act, to describe the content of the Act, to describe the reactions to the Act, and to describe what it's actually done, and to pull that off within 45 minutes. So what happened before the Act was fairly straightforward. We were seeing that the number of uninsured in the United States was steadily increasing. Those are the numbers from 1987 to 2012. And you can see it went from 31 million to 48 million. But what was so disturbing was that growth was faster than the population. And so that the number of uninsured was it went from 13 to 15%. And since we had Medicare that was covering the people over 65, what it meant was that the number of insured and the percentage of insured was very much concentrated in people who were under 65. In addition to that, the United States has an underperforming healthcare system. Here, for example, you can see what I did was I took and listed a bunch of countries where I would not mind being hospitalized if I got sick when I was traveling, ranging from Japan to the United States, excluding North Korea. And what you'll notice here is that the per capita healthcare costs, which is that red line, is very high in the United States. That is, we spend more money per person than any other industrial peer. But at the same time, what you notice is that male and female life expectancy is really very low compared to these other countries. So we are not buying life expectancy with these dollars. And furthermore, if you look at our infant mortality rates, again, the same red line, and you'll see that our infant mortality rates are high, and indeed you can do this for dozens and dozens of healthcare indicators that are mapped for these countries using measures that are standardized between countries. In short, we have a costly healthcare system, but one that is underperforming. And part of the underperformance relates to the lack of insurance, particularly as it affects primary care, because primary care is the driver for public health care outcomes. we could remove all the liver transplants and kidney transplants from Missouri and not affect our public health outcomes at all. But if we ensured prenatal care for everybody, we would radically improve our public health outcomes. And here what you can see is that the people who say don't have insurance are much less likely to have screening colonoscopies. They are much less likely to skip or to have mammograms, and they are much less likely to maintain compliance with medications such as medications to prevent heart attacks, stroke, or asthma attacks. And so that the lack of insurance operates on public health at the level of primary care, which is a key focus of osteopathic medicine. So to briefly summarize the situation before the Affordable Care Act, we had increasing percentage and numbers of uninsured. We had profound barriers at primary care to persons. Furthermore, all of those numbers were trending in the same way. That is, healthcare costs were rapidly accelerating, and the disparity between us and other industrial countries was widening. That is, the gap between our infant mortality and the infant mortality of the European countries was actually getting broader, worse, despite the improvements in infant mortality in the United States. So in that context, the Affordable Care Act, also known as Obamacare, was passed. And it consisted of three major components. First, it consisted of a set of insurance reforms. Now, prior to the Affordable Care Act, if you had leukemia and you applied for insurance, they would insure you, and they would exclude not only your leukemia, but all leukemia-related conditions. Now, the same would go for your asthma. They would exclude your asthma-related conditions. I'll skip obstetric care for a moment. Furthermore, they didn't have to accept you as a patient at all. So if in the past you had, say, filled a prescription for HIV medication, they could just say, we don't want to insure you. Okay, you're not in the pool. And furthermore, to make matters even worse, if you went and filled a prescription for adriamycin, they could say, fine, we're going to cover it because your adriamycin, an oncology drug, is covered under this policy, but we are going to cancel your insurance and simply reimburse you your premiums for the rest of the year. Good luck getting new insurance. We really wish you our best, okay? And then they also put on very high copays for essential primary care services like colonoscopy, mammography, flu shots, and the like. So there was the insurance reform block. And then the second thing they did was they standardized the insurance into 4 core policies to prevent people from buying policies that had little fine print in them that wiped out benefits that they weren't expecting to not be there. And so there was the bronze plan and the silver plan and so forth. And then the third part of this was that they said we're going to put federal incentives on states to expand their Medicaid. I'm going to talk about that later on. Now, one of the things that the feds did not do was they did not nationalize the healthcare system. And they also said we're not going to establish a federal group insurance policy. You get a group policy through your employer or some other place, otherwise you purchase an individual policy. I'm going to come back to that later. They funded it with essentially an employer mandate saying if you, the boss of an insurance company, don't cover your employees, then we're going to tax you because they're going to be coming to us for subsidies anyway. And there was also an individual mandate. Now, I'm sure that in Missouri you still have volunteer fire departments, okay? So if you've got a volunteer fire department in your town and you don't pay the subscription fee and your house catches fire and he's your next door neighbor, the fire department will rush out, pour water on top of his house and let yours burn because they can't build a truck or they can't buy a truck without you paying your premium on a regular basis. That's a volunteer fire department. And the problem is that unless you have everybody into the insurance pool, you don't know who in this crowd is going to need a liver transplant. And so all of you have to chip in. And so the mandate was essentially a cost to cover the fact that if you have the need for a liver transplant and show up, you won't be left dying in the emergency room. Then they put some taxes on, and probably the most interesting tax that I'd like to focus on today is a tax on health insurers that make money. This, for example, is United and Humana. And you've heard of them pulling out of various markets. And part of the reason they're pulling out of markets and why the Blue Cross, Kaiser are able to stay in markets is because they both have to pay a profit to their shareholders, okay? And they have to pay this tax, and so they're being pulled out of the market. And it's not the Affordable Care Act that's doing, it's their profit and the tax. Now, the reason for the tax is that basically they have to raise the health care prices in order to make a profit for their shareholders, and so they tend to be more inflationary on the market. Now, the Affordable Care Act, with that design roughly, and I'll talk about it more, passed the Senate on a straight party line vote. Democrats controlled the Senate at that time. And it passed the House with all Republicans voting against it. And also, there were 34 of the Democrats voted against it. But basically, by saying that the Affordable Care Act would not cover any abortion services, enough anti-choice Democrats came over to enable it to pass the House. And then after that, there were 54 votes to repeal the whole thing. I'm going to make a few comments on the Affordable Care Act and women because the act is designed, actually has an interesting gender slant to it. Women pre-Affordable Care Act carried those red policies. That is, they were insured by their husband's policy in workplace policies. So if their husband suffered, either left them, that's not suffering, well, it depends on the circumstance, but if the husband divorced them or abandoned them or lost his job, then the woman got uninsured through no act of her own, but by the virtue that she was a dependent on the husband's coverage. Now, there was also a remarkable set of gender-based insurance pricing. A 25-year-old woman across the United States paid approximately 85% more for her health insurance than men. Why? Well, it's fair. Women get pregnant and men don't, right? And so they also take mammograms and men don't. And as a result, a large number of women simply turned themselves into men for the purpose of their health insurance and said, well, I'll exclude maternity benefits. And now, in fact, this was so strong that a woman non-smoker was charged more than a smoking man. Now, you all know, because you're all in medical school, that most pregnancies are engendered by reasonably cooperative endeavors between men and women. And, oh, come now, it's okay. And so that this structure of insurance actually was simply a social policy which allowed men to escape the cost of childbearing, which they, in fact, had been partly engendering. Now, in addition to that, when you look at households, you see that orange slice is single-parent households with moms, and the blue slice is single-parent households with dads, and the rest are two-parent households. And what's so interesting then is that women are 5 times as likely to be the parents, custodial parents of kids than men are. But at the same time, as we all know, there is a gender difference in salaries such that men are paid more than women. And so that these women who are much more likely to be single parents, at the same time were situated in the economy so as to be less likely to afford policies. And so there was a mechanism of subsidization to handle that. Now, to make matters worse, the insurers, in response to the rising premiums of health insurance, were cutting dependent coverage so that a woman or a family with kids was much less likely to have the kids covered. And so these kids who were basically, by and large, relatively low-cost insurance items, okay, they don't need liver transplants very often. They don't have high blood pressure medicines very often. We're still being sliced out of the healthcare system. And so what the Affordable Care Act did for women was it said, one rate cell, you can't charge men and women different rates. And furthermore, all kids are covered by their parents' policy up to age 26. How many of you are under 26? All right, basically, you're all covered because of the Affordable Care Act, okay? That's just the fact. And it barred copays on preventive services. And then it expanded the Medicaid system, and I'll talk about that later, because the Medicaid system picks up very poor households. Needless to say, this is an outrageous program. And so it quickly entered the spin machine. My favorite, second favorite, is Ms. Boonstra. She was all over television with this ad. My insurance was canceled because of Obamacare. I feel lied to. Now the out-of-pocket costs are so high, it's unaffordable. If I don't receive my medications, I will die. She had cancer. Now that's a very provocative statement, and one that would move anybody to want to rescue her. Unfortunately, none of it was true. And in fact, finally, the Detroit Free Press, since she had been informed of this in a letter from Blue Cross, she was not canceled. She was simply moved to an Obamacare or Affordable Care Act compatible policy that included those various insurance reforms, like no cancel on claim. So they went to the president of Blue Cross, who wrote a note saying, you are transferred to a new plan. It's going to save you $1,200 plus a year on your medications, and it doesn't affect your doctor and hospital at all. Then I took it over to her house with the cameras rolling, and she said, well, that can't be true. I don't believe it. The ad was funded by the Koch brothers. Now, my all-time favorite has to be Representative Michael McCall of Texas. He's worth $300 million. All those of you in this room who are worth $300 million, raise your hand. Okay, we got one hand in the back. Will the donor, two. The donor committee, hit those up for a new building. Mr. Speaker, I lost my health plan. I have 5 kids. My premiums have gone up significantly. I don't know if I can keep all the same doctors that I had to treat my kids. Oh, really? At the meantime, he's in Texas, which did not do the Medicaid expansion, and thereby left 1 million people out of health care insurance. And he got the new policy that said guaranteed issue, no cancel on claims, no restrictions on pre-existing conditions. Then there was the death panels argument, and you could find these hearses running all over the country. Now, if I was designing a death panel, okay, and I've been accused of that. I'm called Dr. Death for end-of-life care stuff. If I was designing one, I would not have a policy that said 130 million people could not be denied coverage for pre-existing conditions. I would design my death panel so the instant you sneezed, I would cut your coverage, okay? I would not design a policy ensuring that you had mental health coverage because suicide is a reliable way to kill people. And I would not design a policy saying there's a lifetime limit on your costs because you might need a kidney transplant. Nevertheless, this is a death panel policy. And then there was a whole bunch of stuff about budget busters. I made this slide and then I looked up seekingarrangement.com as a way to fund health insurance and was aghast. And then the most peculiar of all is keep government out of my Medicare, you damn socialists. And then there were the docs. And the doc argument went like this, that first off, if we brought all these millions of people into the healthcare system, we would swamp the capacity. And so what would happen was access would decline because queuing would go up. And then there were also the docs who said, I won't take care of people who support this act, like this urologist in Florida. Well, you know the problem, and you know the design, and you know the spin. It's reasonable now to ask for the data, right? I hope this audience is in favor of data. Oh, okay, I'm seeing some thumbs up for data. One piece of data. This is what happened to the uninsurance rate when the Affordable Care Act went into play. It was 17.3% and rising when the act went into place. Now it's down to 10.8. That's a good thing, okay? And it's very clean that it's related simply to the act. The uninsured by age has steadily dropped. That's through a year ago. I just got the data yesterday on the very recent uninsured by age, but I didn't have time to put it into the slide. And you can see that at all ages, the number of the percent uninsured has dropped. Now, this is kind of an interesting policy because the question is, are these people coming over to a government policy, Medicaid, or are they able now to buy a private policy? And you can see actually that both phenomenon are occurring. They're able to buy marketplace insurance and Medicaid and go on Medicaid. The reason kids are the same under 26 is because that provision went into effect in 2013. Now, there was this Medicaid expansion, and let me tell you a little bit about how that worked. And you'll notice that Missouri and Kansas are yellow on this map. Those are orange. The orange states did not do the Medicaid expansion. Basically, what this says is that states who say that somebody can get on Medicaid up to 133% of poverty, which is $27,000 for a family of three, which I think we would all agree is really a tight place to live, that the feds will cover all new state enrollees for 3 years and pick up 96% of the cost for the next decade. The blue states took that deal, and the orange states did not. Now, this is a very important graph. The 2013 map is a county map of the United States showing the counties where there's more than 16% uninsured. And you'll notice that the map of the United States is largely deep purple. You'll notice that after the Affordable Care Act went in, basically in the states that adopted the Medicaid expansion, which are outlined in black state borders, you'll notice that they flipped down all the way to the under 8% rates, or certainly down into the 10% rates. Look at what happened to Pennsylvania. You all know where Pennsylvania is, because between 2014 and 2015, Pennsylvania and Indiana finally adopted the Medicaid expansion, and you can see them flip between 2014 and 15, where they hadn't flipped before. On the other hand, if you look at Missouri, you see it's remaining much of its deep purple color, and Kansas is a little bit of a mixed bag because of some Medicaid reforms. Now, if you take and compare Arizona and Kentucky, which are two states, Arkansas and Kentucky, two states which took it relative to Texas, which did not, you can see that in Arkansas and Kentucky, the percentage of the population with doctors increased 10% relative to Texas. At the same time, those who were delaying care because of costs dropped. Those who skipping medicines because of cost dropped. Those who had trouble paying their medical bills dropped. And those who had seen a doctor in the last year went up. So basically, this is a good deal. But for all this is just insurance. This isn't access to doctors. Now, you got to start this story by asking yourself, well, were the new people coming into the health insurance market sicker than those who were already in? And it turned out they were. The people who came in by the Affordable Care Act had higher rates of hypertension, higher rates of diabetes, higher rates of depression. They were more likely to be admitted to hospitals, more likely to have and need clinic visits, and more likely to need specialists. All that was true. But this is what's so cool. Here in this graph, what you see is that in the states that took the Medicaid expansion, that blue line on top, that what happened was that their access to doctors went up. Primary care doctors went up. Whereas in the states that didn't take the expansion, the purple lines, there was no change. And furthermore, in the states that took the expansion, the people who didn't get insured acted just like people who were uninsured in the states that didn't take the Medicaid expansion. Surprise, giving people health insurance improves their use of physician services. Does this apply to all physicians? Yes, it does. It applies to primary care doctors. It applies to OBGYN. It applies to surgery, and it applies to all other specialists like allergists, nephrologists, cardiologists, and all the rest of it. You can see that in the Medicaid expansion states, the use of physicians popped up once the Affordable Care Act went into play. Well, the other argument was if we open the system this wide, then what will happen is that the queuing will result in huge delays to get care. Well, really not so much. Primary care access to care was within 2 weeks, okay? In most cases, some were a bit longer. And there was also a decline, unevenly spread, in the lack of insurance by different races. We're at the final point. 2 final points, actually. Has this bill been inflationary? Now, you remember that the argument of seekingarrangement.com was that this would simply create an unbelievably costly healthcare system. And the data doesn't support that. These are 3 different analyses done by the Brookings Institute, which is a conservative think tank. And what they show is that the market premiums are lower once the ACA popped into place in 2013. And furthermore, you can see from the 2009 estimates of healthcare inflation and the 2014 estimates of healthcare inflation that the actual healthcare inflation in the graph on the right was lower than projected. But these are numbers that look at the big population. What about over the back fence, over the kitchen table? This is population surveys looking at the percentage of people who are delaying care because of fear of cost, that orange line. And you can see that the percentage of people who are delaying care because of cost dropped between 2013 and 2014. And the people who were having problems paying their medical bills dropped during the same period. And the people who were not getting care because of cost, according to the Center for Disease Control, dropped during the implementation of the Affordable Care Act. And furthermore, that healthcare inflation during the period of the Affordable Care Act has been at the lowest level that we have seen since right in the 1960s, when President Kennedy briefly tried price caps, which was a terrible strategy and failed. The Affordable Care Act relies on essentially market competition. Now, you got to remember that the data on the Affordable Care Act comes in waves, okay? The insurance naturally is the first set of data. The last set of data to come in will be public health outcomes. We have now data on insurance. We have data on use of physician services, but what we don't have is data on actual public health outcomes. We don't have data on neonatal mortality. We don't have data on overall death rates or life expectancy. Now, that data is not available and will take a while to come in. So at this point, I've got 13 minutes for questions, both from this room and maybe from the offsite centers. So fire away. Yeah, in the back. You, blue t-shirt. You got to get the mic, though. My ears are ruined by the 1960s.
So I don't mean to make this question overly political, but to me, one of the most interesting things.
You can make it as political as you want.
So in your view, what do you think is the most significant reason why Republicans are so adamantly opposed to the bill? I mean, whether it be that Medicare or healthcare in the United States is 20% of the GDP, so maybe that's why, like theoretically, or the fact that they're afraid that businesses are going to employ less, or I just am curious to think that what's your point of view of why Republicans are so adamantly opposed when it's such a public health necessity, when you can clearly see the data?
All right, well, that's a fascinating question. I'll offer my opinion, but keep in mind I could be shifting over to punditry. The reason we got Affordable Care Act when we did was that the overall healthcare budget was moving to around 18% of the total U.S. budget, okay? Let's call it 20% just to make the numbers easy. And Europe was running around 10%. What this means is that if you had 2 cars, each selling for 50 grand in the United States and trying to export them, okay, the $10,000 per car would be an invisible healthcare component. That's how much of the economy was in the healthcare system. Whereas that car would be made in Sweden with a $5,000 healthcare bumper that nobody could see. And so one of the issues had to do was that the cost of healthcare in the United States was hurting export markets. And so at that point, it created a little window of opportunity with Democratic control of the Senate to pass this, as long as there wasn't nationalization of the insurance market or the healthcare system. But the bigger issue, I think, goes something like this. All healthcare insurance is fundamentally a redistribution of wealth, from the healthy and well to the sick and disabled. Because if you are disabled, you will earn less and you will have higher healthcare costs. And if you are able-bodied, you will earn more and have lower healthcare costs. And in an insurance mechanism, there's a transfer here from the wealthy well to the sicker poor. And the European systems are willing to adopt that as a form of social solidarity. The United States sees that as a redistribution of wealth and therefore politically unacceptable. And in addition, what's happened is that excuse the political term here, grasping by this rich well group over here, has been aggravated by an increasing concentration of wealth over here, which has had the paradoxical effect of made them less willing to think about transfers back over to this side. So that's in a nutshell. Does that answer your question? This guy over here, oh, there's one over here.
So my question kind of has two parts. So I remember when the Affordable Care Act was rolling out, a lot of the pushback from it was coming from physicians. And an argument I heard frequently was they were worried that physicians would make less money.
Yeah.
So I'm just curious what the data says on that. And then the other part of the question is, if that is the case, it seems counterintuitive that the Affordable Care Act didn't have any initiatives to make healthcare education more cost effective. And I'm just wondering if you have any comment about that.
Yeah. It's a little too early to look at the physician salary data in detail. One of the things that's quite interesting about the U.S. healthcare system is that we use a much greater specialist to primary care ratio than other countries. And at the same time, we pay higher salaries to that specialist component. But the other thing is that if I send you to a cardiologist for treating your blood pressure, the cardiologist will in turn use a higher degree of healthcare infrastructure for managing your high blood pressure, perhaps exercise test, for example. Whereas a primary care doc will say, well, you got high blood pressure, and say you need these drugs, okay? And so that the thing that seems to be happening is that the specialist to primary care ratio looks like it's shrinking a bit, but we won't have good data on that until next year or two, okay? The physician salaries, as I recall, are something like 20% of the total healthcare budget or something. It's a big deal. But I think that what you're going to see is that the primary care salaries are going to continue to rise, but the specialist salaries will drop. And part of the pressure there is by putting healthcare, insurance systems tend to capitate healthcare. That is, they create one budget for all of your healthcare. And so paying say, an ophthalmologist $350,000, $400,000 a year to do cataracts is just not going to happen. Yeah, this person over here. Y'all having a good time?
Hi, so one of the concerns I had heard was from a hospital perspective of being able to afford increases in Medicaid and Medicare patients.
Right.
So for example, if a Medicaid or Medicare patient comes in, the government will pay about 75% of the cost that it would cost a hospital to actually pay for that. That typically in the past was offset by, like there's a code with a certain price and
Yeah.
insurance companies have certain percents that they pay on that. And it'll be like way higher than what you would cost basically for a Medicaid or Medicare patient.
Yeah.
So if you have this expanse or a massive expansion of Medicaid and Medicare, I think one of the concerns was hospitals being able to stay open because they're going to have this big increase in Medicaid and Medicare patients that are typically wouldn't be offset by the insurance companies. Is there a solution for that? I know that's like a current concern, or is that just like a inappropriate concern?
Yeah, there's some data on that. I should probably throw that in. It's pretty cool. What's happened is that the hospitals are having to eat much less bad debt because the overall rates of insurance and the number of people who are insured hitting their emergency rooms and coming in through primary care clinics is actually higher. And so, although there are some budgetary constraints on how much they can spend per patient, the number of patients who are completely bad debt has simply dropped. And that's producing an additional revenue system for them. Now, the hospitals that rely on fee-for-service, of course, are chopped on the outside. And one of the interesting subsystems in the healthcare system, my mic on? Okay, one of the interesting subsystems in the healthcare is Planned Parenthood, for example. Planned Parenthood provides reproductive health care and abortion services. But the interesting thing is that when reproductive health care as a form of primary care was moved into all primary care policies instead of sitting outside of those, Planned Parenthood actually has had a decrease in the demand for those services because they're covered in the general health care system. And so the abortions are, as a percentage of their clinical revenues, rising because abortion's not covered under the Affordable Care Act and not offered by other providers. That's a tangent to your question. But the fundamental answer to your question is that the increased number of insured persons in hospitals is offsetting the low reimbursements on some of the government policies. We got a green shirt over here, and then in the back a white shirt. I'd call you by name, but
Sterling.
call you green, what?
My name is Sterling.
Sterling?
Yeah.
Like the metal?
Yeah.
Okay. Sterling.
So when the Affordable Care Act first came out, I was in undergrad.
Yes.
And I remember I was working at an art store, and my summer job was helping people pick out oil paints. And I was working full time.
Pick out
and
what?
Oil paints.
Oil
for
paints?
painting
Yeah,
at the
yeah.
art store.
Okay.
So when this came out, I remember the first news that I got was, hey, I can kind of leech off of my parents' insurance. And I thought that was awesome. So I was very happy about that. But then I went to work and my employer said, all right, you can no longer work full time because if all full-time employees now have to get insurance and we're not playing that game, so we're just going to hire a bunch of part-time employees. And I feel like that happened at a lot of places that I saw. A lot of employers just kind of said, yeah, we're not playing those games. We're just going to cut everyone to part-time instead of full-time. And for me, as a younger, healthy undergrad, I didn't, yeah, it was cool that I could be on my parents' insurance, but I was more sad about the fact that my hours got cut. And so what do you think, what's your opinion on that, and what do you think would be a good solution so that, I mean, I feel like a lot of employers, if for the lower paid jobs especially,
Yeah.
this affects, like lower paid, non-technical jobs, hours are getting cut so they can kind of get through that
Yeah.
little loophole there.
To the extent that people under 26 are covered, I think that the Act should say that counts as a covered employee, personally. But one of the things that was looked at was whether the employer mandate did result in a decrease of employment. And in fact, unemployment rates have steeply dropped since the Affordable Care Act went into play. The effect on, there were a number of concerns about employment. One was that it would cause people to say, well, I can get my insurance elsewhere, so why should I bother working? Okay. So like you've got a small trust fund with a name like Sterling, your silver. So you could just go and, use that to get health insurance and say, I don't want to sell paint anymore. But the other thing and that turned out to not happen, okay? But the other kind of interesting thing that people are waiting for the data on, it's not available, is this weird phenomenon called job lock. And job lock goes like this. You want, how long do I have? Okay, you want to leave your job because you want to start your own coding company, okay? Because you've seen a lot of coding billionaires and you don't like working as a, whatever you're doing, okay? At a saddlery or selling paints with Sterling back there. And so it turns out that because your insurance won't be canceled when you move over, that you can do that, okay? That's called stopping job lock, and we're all waiting to see if that happens. I think I've used up my time. They said 10-2. Not true? What, 5 minutes? Why are you waving at me? You want to ask a question?
I don't have a question. I was just wishing for the PowerPoint if you could put waiting time CUFD/DO. That would make it so much better.
How's
Everybody-
that? Better? Okay,
One last question up here, and then we'll be done.
one more. Oops.
I was just wondering if you had any data on emergency room wait times or visits per
No.
year?
The
No?
emergency room wait times have basically, well, actually, emergency room utilization is still unaffected, but that's a healthcare outcome that'll take a while to wash through. Partly because the new patient base is sicker and partly because they haven't been trained yet to their primary care docs. Am I done?
Everybody, let's thank Dr. Miles. Make
Thank
sure
you.
you sign in before you leave the room as well.
Hey, thanks very much for coming. Really appreciate it. I just really want to quickly ask about the other part of my question was about medical education.
Yeah.